Hello guys, welcome back to my channel. Today I am here with a very basic topic, that is the cranio-vertebral junction. I will be covering this video in these headlines: the basic introduction of CV junction, the ligaments helping in its formation, few terminologies like basilar invagination, basilar impression, platybasia, and then about few lines and angles and the few measurements at the craniometry part. So let's start with the very introduction of the craniovertebral junction. So if I ask you, what do you mean by craniovertebral junction? That it's the junction between the cranium and the vertebral column. This is the cranial part, this is the vertebral part. So what constitutes the junction are the few bones, their articulations, and the ligaments helping in their stability. Like this is the occiput bone, this is the occiput bone, this is the C1 vertebra, the C1 vertebra, C1 vertebra, C1 vertebra, that is the atlas, and the C2 vertebra, that is the axis. So these bones, the occiput, the atlas, and the axis forms the craniovertebral junction. Their articulation and the ligaments, all these together form the craniovertebral junction. So before starting with the actual pathologies in the craniometry part, I would like to discuss the ligaments involved in craniovertebral junction stability. So this is a very basic diagram I have taken from Radiopedia. So if I discuss, this is a very basic thing that we already have studied in the anatomy. This blue one is actually the anterior longitudinal ligament. This and in anterior aspect of the vertebral column. This continues above the level of the atlas as the anterior atlanto-occipital membrane. Okay, this is the posterior longitudinal ligament, this is a posterior longitudinal ligament, and this continues above this level as the tectorial membrane. Okay, the anterior longitudinal ligament continuing as the anterior atlanto-occipital membrane, the posterior longitudinal ligament continuing above as the tectorial membrane. Okay, next is this the this green one is the supraspinous ligament. This continues above the level of C7 as the nuchal ligament or ligamentum nuchae. This is actually the ligamentum flava. This is the ligamentum flava in between the lamina of the cervical vertebra. This continues above as the posterior atlanto-axial membrane, and above this level as the posterior atlanto-occipital membrane. Okay, so this is the ligamentum flava continuing above as the posterior atlanto-axial membrane between the atlas and the axis, and the posterior atlanto-occipital membrane that is between the atlas and the occiput. That's okay till now. Next is the three more ligaments: the apical, the alar, and the cruciform ligament. So what is the first one is the apical ligament. Okay, apical ligament is this purple one. Apical ligament means from the apex of the dens to the clivus. Okay, this one is the apical ligament. Next is actually the alar ligament. The alar ligament. Okay, see this diagram. This is actually the dens. This is the dens. Alar ligament is attaching this dens to this occipital condyles and the lateral masses of the atlas. This is the alar ligament. What is apical ligament? We already have studied from the tip of the dens to the clivus, the apical ligament side. This is the alar ligament. Next is the cruciform ligament. The cruciform ligament has actually two components. One component is the transverse component, which is actually attaching the two lateral masses of the atlas, and this goes behind the dens. So it keeps the odontoid process very much in close proximity to the anterior arch of atlas. Okay. So we have studied the apical ligament. This one is the apical ligament from the tip of the dens to the clivus. Next is the alar ligament from the side of the dens to the occipital condyles and the lateral masses. Next is the cruciform ligament, which actually has two components. One component attaches the lateral masses and keeps the odontoid process in close proximity to the anterior arch of atlas. And another component of cruciform ligament is actually the longitudinal part, this one, okay, this one is actually the cruciform ligament. Longitudinal part, this light pink color, is the cruciform ligament, and it actually passes in between the apical ligament and the tectorial membrane, and it attaches the tip of the dens to the clivus again. Okay, till now that's okay. So we have studied the cruciate ligament has two components: the transverse part, which attaches the lateral masses and keeps the odontoid process in place, and another is the longitudinal part, which attaches the body of the C2 to the clivus and foramen magnum in the midline, lying between the apical ligament and the tectorial membrane. Okay, till now that's okay. So we know what constitutes the cranio-vertebral junction, the bones, their articulation, and the various ligaments, what keeps them stable at their places. Okay, once we know this very introduction, there are few terminologies in CV junction, that is the basilar, invagination and impression, and platybasia. So basilar invagination, basilar impression, these two terms are actually used interchangeably. However, there is a slight difference. Like basilar invagination is actually a congenital thing. Okay, this is a congenital thing. So what happens in basilar invagination is this vertebral column, there is upward displacement of this vertebral elements into the normal foramen magnum with normal bone. Okay, this is congenital. And what is basilar impression? Basilar impression, this is actually a acquired situation. Why this occurs? Because of the softening of the bones at the base of the skull. Okay, so these two terms we have to know. Basilar invagination is the congenital upward displacement of vertebral elements into the normal foramen magnum with normal bone, while basilar impression means similar upward displacement of the dens, but this is an acquired situation because of the softening of the bones at the base of skulls. And what is platybasia? Platybasia means there is flattening of the skull base. This skull base has an angle, but in platybasia what happens, this angle is increased and the skull base is like very flat. So these two terms you have to keep in mind. The basilar invagination, that's a congenital condition. The basilar impression, which is acquired. The platybasia, which means the flattening of the skull base. With this very basic thing, you have to keep in mind. Let's start with the craniometry. I'm not going to discuss all the lines and angles, but very few basic lines and angles which you have to keep in your mind. Okay, so let's start. First, know the basic terminology. Like this is the basion. Okay, this is the basion. And this is the opistheon. This is the basion, this is the opistheon. So first of all, what is I'll discuss Macrie's line. Okay, Macrie's line. Macrie's line is the line joining the basion and the opistheon. So what is Macrie's line? Macrie's line, I have said basion to opistheon. What's the normal value? Normal value is normal value is 35 mm. Okay, if this Macrie's line is less than 20 mm, means there is foramen magnum stenosis. Okay, what next important in basilar invagination or impression is the distance of this tip of dens from this line. Okay, usually the tip of dens is 5 mm below this line. Okay, but if this dens is above this line, this concludes toward basilar invagination or impression. Okay, so Macrie's line is between the basion and opistheon. The normal value is 35 mm. If this is less than 20, that points towards foramen magnum stenosis. Normally the tip of dens is 5 mm below this line. If the tip is above this line, this constitutes basilar invagination or impression. This is Macrie's line. Next is the Chamberlain line. Okay, Chamberlain line. What's Chamberlain line? It's distance between the posterior pole of the hard palate to the opistheon. This is the Chamberlain line. What's the significance? Significance is if the tip of dens is more than 3 mm above this line, then this points toward basilar invagination. So Chamberlain line is posterior part of hard palate to the opistheon. If the tip of dens is more than 3 mm above this line, this points towards basilar invagination. Next is the McGregor's line. What is McGregor line? Many times the tip of the occiput, that is the opistheon, is not clearly visible. Then we have to take the lowermost part of the curvature of the occiput. So what is McGregor line? McGregor line is the distance from the posterior pole of the hard palate to the lowermost part of the occipital condyle. This is actually the McGregor line. What's the importance? If the tip of dens is more than 4.5 mm above this line, this points toward basilar invagination. Okay, and one more line is there, what is known as the Wycombes line. The Wycombes line is drawn along the slope of the clivus. Okay, along the slope of the clivus. So this is the Wycombes line. What's the importance? Importance is tip of dens should not intersect this line. Okay, should not intersect this line. If this is transecting this Wycombes line, this means there is basilar invagination. So we have discussed the 4 lines. That is the Macrie's line. Macrie's line, if the tip is above this line, then this is basilar invagination. The Chamberlain line, if tip is more than 3 mm, this is basilar invagination. McGregor line is if tip is more than 4.5, it's basilar invagination. And the Wycombes line, if tip transects, then this is basilar invagination. So we learned the 4 basic lines. There is one angle that is known as the basal angle. So where we draw the basal angle is from the nasion to the center of the sella and then along the basion. Okay, so this angle is actually the basal angle. The normal value of basal angle is between 124 to 142 degrees. If what happens in platybasia, the skull base is flattened, like the clivus has lost its slope, the skull base is flattened. So what happens to this angle? This angle increases. So if the angle is more than 142 degrees, this means there is platybasia, that is there is flattening of the skull base. Okay. Also we have to keep in mind few other measurements like the atlantoaxial, that is between the anterior arch of the atlas and the dens, that is the atlantodental index. This distance should be less than 2 mm in adults and less than 5 mm in case of children. If this distance, that is the atlantodental index, is more than this value, that means there is atlantoaxial dislocation. Okay, there is atlantoaxial dislocation. Also keep few other distances in mind, like the next is the basion dental index. From the tip of the basion to the tip of the dens. This distance should be less than 10 mm. Okay, this distance should be less than 10 mm. And another concept is the Powers ratio. Okay, Powers ratio is actually the ratio of the this line between the posterior arch of atlas to the basion and the anterior arch of the atlas to the opistheon. Okay, so Powers ratio is this distance basion to posterior arch of atlas to opistheon to the anterior arch of atlas. If this ratio is more than 1, what do you mean by more than 1? Means this distance has actually increased. What do you mean by increased distance of this basion to posterior arch of atlas distance? Means the skull has actually, there is anterior translation of the skull over the vertebral bone. Okay, so we have discussed the introduction, what constitutes the cranio-vertebral junction, the bones, the ligaments and their articulation. We have discussed what do you mean by basilar invagination, basilar impression, the platyvasia. We have discussed the Macquarie's line, the Chamberlain line, the McGregor's line and Wycombes line, and the angle, that is the basal angle, and few other measurements like the atlantodental index, the basion dental index, the Powers ratio. Okay. So let's see a case here of cranio-vertebral junction MRI. If I tell you the basic craniometry, then this here is the Macquarie's line, and we can see the tip of the dens is actually crossing the Macquarie's line. Next, this is actually the along the slope of the clivus, the Wycombes clivus line. Okay, and we can see the tip of the dens is located dorsal to this line. Okay, so again this points towards the diagnosis of basilar invagination. Also in this case there is increased atlantoaxial distance, that is here 7.5. The normal value for this adult female should be less than 2 mm. Here it is 7.5, that is there is increased atlantodental index. So this is a case of vertebral basilar invagination along with atlantoaxial dislocation also. So if I say there is increased atlantoaxial distance, there is a retroflexion of the dens, and this retroflexion and kinking of dens is causing signal here at the cervico-medullary junction, that is compressive myelopathy. Also, if you closely visualize the posterior arch of the atlas is not visualized because there is complete occipitalization of the posterior arch of the atlas, as well as the anterior arch is upward displaced, that is partial occipitalization of the anterior arch of the atlas is there.